And so what you're going to be hearing from now is really sort of the forefront of some of that effort, which is occurring actually in the military. The military, I think, is more attuned to looking at a population and saying, we need this population to not just not be sick, but be able to go the distance. So we're going to hear from Eric Schoonmaker and Ben Kligler. Let me introduce both of them, and they can just proceed and speak in order. Dr. Eric Schoonmaker is a retired lieutenant general who served 32 years in active service in the U.S. Army as their Surgeon General, where he was responsible for the health and well-being of really everyone in the Army, and by doing so, also the nation's readiness. And then after Dr. Schoonmaker, Ben Kligler will speak, and he is the National Director of the Integrative Health Coordinating Center of the Office of Patient-Centered Care and Transformation in the Veterans Administration. Before that, he was the Associate Professor of Family and Social Medicine at Albert Einstein College of Medicine, and was the Research Director in doing research on integrative medicine at the Continuum Center for Health and Healing. And he has also been the former chair. He was chair of the consortium before I was. So I'm introducing two really good friends. Eric Schoonmaker will speak first.
So the animation. Well, good afternoon. It's really a privilege and a pleasure to be here today, and we're just working out the fact that there's no animation, so I'll have to get animated up here. It really is a privilege to be here, and I really appreciate the attention of such a distinguished group. Looking around here, I see a lot of friends and colleagues, and I notice that even the folks I work with, a few of them came down here to make sure that I speak the truth. And I'll probably get a grade at the end of this, so really be enthusiastic about what I say, would you? Also, really a privilege to be and pleasure to be here sharing the podium with really leaders in this whole arena. And Margaret has been working very hard during her tenure in the consortium to try to get my community into the consortium. We haven't given up on that. We're still working. And I can't say enough good things about the Veterans Administration and the work that Ben Kligler has been doing, and Tracy Gaudet and Friedhelm Sandbrink and others who have really advanced this whole effort of integrative health, and especially that which applies to pain. So what I'm going to do here for the next few minutes is to take a little bit of a focus away from the whole broad area of health and well-being into one that is not that much narrower, frankly, when it comes to our communities, because there is no complaint that is more frequent or more a problem for patients than is pain. Pain is the number, in the military community, and I think the VA is the same, pain is the number one, number two, or number three complaint of every patient, regardless of why they've come. And if you think about that, and if you're a clinician as well, whether you're in sports medicine or in an orthopedics clinic or family medicine, wherever you are, you probably can mentally reconstruct the fact that the patients that you come to see in the main, if not in totality, are coming to you because they're in pain in some way, shape, or form, and are trying to work through that. And what I'm going to talk to you, and I think Ben's going to also touch on it, is what we in the federal medical community, especially the VA and the DoD, are doing to try to advance the use of integrated practices. Now, I was really pleased that the congressman helped me. Normally when I give this talk, I usually start off with a picture of a cholera epidemic victim being resuscitated somewhere where cholera is raging, with fluids, is being cared for this life-threatening diarrhea that results from it, and antibiotics at some point. But you don't treat cholera by just treating victims. You go back, as one of the fathers of epidemiology, John Snow, did in 1853 in London, an anesthesiologist himself who studied the epidemiology of where cholera victims were emerging from London and realized that they were clustering around the so-called Broad Street pump. And when he took the handle literally off the Broad Street pump, the epidemic stopped. Why? Because some mother had washed a diaper contaminated with cholera in a small depression in the street near the pump. It infected the water supply, and people then transmitted cholera. We are not in an epidemic of opioid addiction. We're in an epidemic of epidemics. And as one of the congressmen said, the epidemic begins with the epidemic of poorly managed pain in over 2/3 to 3/4 of the patients. So the diversion, overuse, misuse, ultimately opioid use disorder and addiction of the majority of our patients begins with pain management. And whether it's a 93-year-old woman who had a hip replacement, whose daughter I sat next to on a plane going to San Diego to the meeting that was alluded to earlier that Bob was at and Len, where her mother, over the course of 6 weeks of recovering from her joint replacement, got addicted to OxyContin. Why? Because she was given a handful of OxyContin by her doc, and she was told, take this OxyContin every 6 hours for as long as you need it. And 6 weeks later, she's addicted. She's 93 years old, and this 65-year-old daughter has to go out and put her through cold turkey recovery. There is no program that she could afford to put her into, and there's no, except for a street program of street addicts and drug users in the San Diego area. She couldn't afford to put them in a high-cost drug rehabilitation program. So she said, the worst experience of my life was taking my 93-year-old mother through drug withdrawal from opioids over the course of the weeks that followed. And that's not an isolated event. That was a random stranger I sat to next to the plane. And I know Delta has figured out how to put me in the middle aisle, the middle seat, but they're not so smart to figure out how to put us next to people that are suffering from what we are studying. That event and that encounter is so common for us right now. So I'm going to talk about what we've done in the military, and quite frankly, I labeled this as the military and the VA because the VA is now leading the nation, in my view, in this effort, and needs to be commended for the work they're doing. Both Tracy Gaudet and Ben and many others. It's a really phenomenal thing. These images, I hope you stick, regardless of whether you remember what I say. But the images that I couldn't have put up 10 years ago of a soldier doing yoga, we couldn't even call it yoga. It was combat movement. But now that we know there's good evidence for these things, people are very accepting. And I'm privileged to work in a community, quite frankly, that our surveys every 2 years of use of these has shown that the military community is actually very receptive. Whether that's because, as the cynics say, that we frustrated them by not giving them treatments that work for them, or whether it's because many service members are stationed in foreign environments where they learn this. My own wife learned about integrated practices from a German acupuncturist on our second tour in Germany, or they marry a Korean, or they're assigned to Japan. But for whatever reason, they're far more receptive to the use of integrated practices than probably any other community. And now we're tracking that, and it's a remarkable experience for them. Real quickly, I'm doing this in my private capacity. I have to acknowledge the fact that my wife is a mindfulness meditation and yoga instructor. I don't know who speaks for the DoD in the U.S. and my university, but it certainly is not me. So there's no animation here, but all this is showing you is most of you are aware of the fact that we are experiencing unprecedented survival from battlefield wounds. If we tell a soldier, a Marine, an airman, a sailor, a Coast Guardsman, if you are injured in combat now and survive the initial wounding experience, the likelihood that you will survive treatment and recovery and rehabilitation is over 95%. That's an unprecedented, and we've done that through all of the efforts here, from better training and better equipped medics to soldiers themselves who know how to put a tourniquet on, as we've taught the people that treated then at the Boston Marathon bombing and others. Right back to evacuation. The Air Force has now put literally intensive care units in the air. We can put a soldier who's lost 4 limbs and half his blood volume on a plane within 10 hours after getting injured and flown back to the United States in an intensive care unit inside a C-17. That has never been achieved before. And frankly, the Air Force was able to do that for the first 50,000 wounds and injuries and illnesses of these war. 50,000 patients moved. They did not lose a single patient, despite the intensity of their wounds and the care. So it's just remarkable achievements. And then the rehabilitation. That soldier in the middle down there is actually a soldier we retained on active duty with 2 amputations. He became one of my non-commissioned officers that helped run our rehabilitative centers. I plucked him off the 2nd story of a climbing wall that we had at Walter Reed. He had adapted his prostheses to be able to climb the wall, something that I don't have the courage to do, quite frankly. And thank you for that reminder, Margaret, that we're all a little bit overweight. I am not going to hit the slider bar afterwards. So here's the pain challenge that we have. And I labeled this as that the military is the gateway into the Veterans Administration. Ben and I were just talking about this. We need to develop within the military the expectations and the processes and the orientation of our active duty that they can expect to see within the Veterans Administration, and so that we're one continuous, even though we're 2 executive branches with 2 different cabinet secretaries and 2 different budgets, we really need to build, continuous programs of health and well-being. And what you see here is that veterans and soldiers, and I'm a soldier, so I'll say soldiers instead of having to say each time soldiers, sailors, airmen, Marine, Coast Guardsmen, but I mean that. All service members experience more pain on average, and that appears to be even more so for women veterans. Remind you that between the VA and the DoD, we manage about 20 million patients. In fact, when we were out at the meeting that we talked about earlier, Bob, I think we counted the fact that the groups represented from Aetna to the military to the VA and others represented, 60 to 80 million Americans. We were talking about close to 1/5 to 1/6 of the whole population of the United States represented in these integrative efforts. And it's very important to realize that relative to the population at large, our patients experience far more pain. As you can see, it's musculoskeletal pain. And why is that? We all know about the combat wounds, and we can expect that someone who's lost a limb or had a severe, grievous injury to an extremity, and for every amputation, by the way, we have 7 times as many just grievously injured extremity wounds. The fact is that service in uniform is a contact sport. And what you see here, don't get caught up in the words. What was that, this? Okay. But look at the kind of the melody of this. And that is, relative to everything else across the first decade of the 21st century, kidney disease, cancer, cardiovascular disease, renal disease, which remain pretty flat. The 2 lines you see are behavioral health and musculoskeletal injuries presenting at outpatient clinics. And this is real data for across all of the services. So we say that if you're a 35-year-old light infantryman or Marine whose average basic load is 120 pounds and you're working at 8,000 feet and you're running 12 miles with a pack and a weapon, by the time you're 35, you've got a 65-year-old neck and a 65-year-old knee, and your back is shot. And that's what we're seeing here, is musculoskeletal injuries. So it's not wounds per se. The other thing we know is that pain, especially chronic pain, which is different than acute pain, and if we get a chance we can talk about that, once pain becomes chronified after 6 weeks to 3 months, it's no longer about tissue injury and nociceptive problems with nerves. It's a brain disease. And it's unique to every individual that revolves around your emotionality and revolves around your memory of pain, and with overlays of how your brain thinks of pain and the rational construct. And so these mind-body practices are very appropriate because they're probably interacting and interfering and redirecting parts of the brain in ways that we don't still understand. Very important is chronic pain very rarely in our population, and this comes from the VA, but it's overlapped with what we know in the active component, is very rarely a solo problem. It's usually in an interaction with a concussive brain injury, with depression, with post-traumatic stress disorder, with an alcohol drug problem, with other things. So it's a complex array, and we have to approach that as a biopsychosocial construct that, quite frankly, early pain centers like John Vanicka's Center out at the University of Washington also recognized and began to work on. And we've fallen off the curve of doing that. You all know this, that whereas in the 70s and 80s we were facing epidemics of these drugs and the use of these drugs that were restricted to cloistered areas, often of inner cities and selective ethnicities. Now we're facing an increasing rate of the use of prescription opioids that have led to an unprecedented death. This is the most serious health threat to this nation that we've suffered in 240 years. This will exceed the impact of the 1918, 1919 Spanish flu epidemic. It killed 20 million people, 30 million people worldwide, but that happened in a year. It took people out. It killed half of all the people who died in World War I from non-combat wounds with Spanish flu, but it was over in a year and was gone. What we see now is an epidemic of epidemics with pain leading to opioid use, leading to hepatitis C epidemics where unsafe needle practices are used, to the loss of human potential. Parts of the country that have less than 4% unemployment, but they can't employ anybody because they have a positive urine test, or they're a felon, or they're incarcerated. So now we've lost that. And now, for the first last 2 years, we've seen declines in life expectancy that are directly attributable to this problem. And we aren't spared from this. We saw that. What we did is I stood up a task force called the Pain Management Task Force in around 2008, 2009. I said to them, look, based upon experiences of my wife and other patients of ours that I've seen, you need to open the aperture to integrative practices that are evidence-based. And to their credit, they came back, including Trip Buckenmeyer, Dr. Buckenmeyer, who helped lead this, and is himself an anesthesiologist and a proceduralist, says, you know what, I didn't realize this, but there's better evidence for the use of acupuncture, yoga, chiropractic, guided imagery, mindfulness meditation than there ever has been for chronic opioids. In fact, what is the evidence for the use of chronic opioids in chronic pain? None. None. There are no reputable scientific studies that show that chronic opioids in chronic pain work. In fact, there's lots of evidence that it causes huge damage, and even evidence that it may make pain worse in some patients. And yet the evidence for these practices are out there in abundance. Institute of Medicine, now the National Academy, followed a year later with their own larger study for the whole nation, pretty much overlapped. And what we saw at that time was the acupuncture, biofeedback, and yoga and meditation. Now we've expanded that to these music therapy actually has very good literature, mindfulness meditation, medical massage, Tai Chi, probably for cervical pain, the movement therapies. These all have good scientific literature and research behind them. This is to show you the coordination of the federal system in this regard. In the middle is a timeline from 2008, 2009 up to the present, and what you see there is the VA led, DoD followed. We put together consolidated products that are at the bottom here, Institute of Medicine study with the IOM report on pain in America. And then the NIH's Interagency Pain Research Coordinating Council was tasked after the IOM report by the Secretary of HHS to come up with a national pain strategy, which is under that star there. And that group put it together, published it. The National Center of Integrative Health then brought together the VA and the DoD. We now have a platform for doing research in integrative health that's been very successful. A couple of things real quickly, and I'm going to get the hook. If we can do one thing in this world that will transform it, it's adopting this way of measuring pain. We got into our problem in part because we were asking every patient, you've been to the hospital, the custodian asks you if you're in pain, the guard asks you if you're in pain, the clerk asks you if you're in pain, doc asks. We started chasing zero, as Jane Valentine says. This tool is that analog scale, but it adds functional interruption, and it asks, how is the pain interfering with your life? Sleep, mood, stress, activity. And when you ask patients that, it changes the whole way we go after this to one that's functionally based. We also have other tools. Last slide, and then I'll quit. The Samueli Institute helped us with this. These are the 4 quadrants that we feel are very, very important to attack in policy. In order to have an effective integrative program, you, number one, have to have an integrative care delivery system that's multimodal, that's multidisciplinary, that's team-based, and that's focused on patients. You need to get patients involved. You can't have patients passively looking to the system to inspire them to make things better. We need to engage pediatric populations and sports teams. You need operations within the health system that support it, and most important, you need a sustainable business model. The reason this is not being done, even though we know it works better, is there is no business model that supports this. So with that, I'm going to step down and say thank you very much. And Ben?
I want to thank General Schoonmaker, because that was just a perfect setup for what I want to talk about, which is really the, so there are two ways to look at this field. There's a way to look at it that has to do with the modalities that we can offer people, things like acupuncture, chiropractic, massage, tai chi. And then there's a way to look at it which is really about the, quote, transformation that we're talking about, which is about bringing control and access to and decision-making power over health back to the person and making that the focus of the care. And that's really where the transformation comes in. So what's been motivating us in the VA is really the fact that that's what we're working towards, and the complementary and integrative health modalities, which I'm going to talk about at the end of my time briefly, are really in service of that. So I'm going to talk to you about the whole health model that we're moving forward in VA as kind of a manifestation of what that transformation can look like. So just a quick rundown on the VA for people that are not familiar. Largest federal healthcare system in the U.S., I think bigger than the DoD, but I could be wrong. We have 18 VISNs, which are the regional networks that the VA is divided into. It's 150 plus medical centers, about 1,000 or a little bit more outpatient facilities. There are 9 million patients enrolled in the VA. Roughly 6 million of those are in active care, and there are 330,000 staff. So this is a big organization. So what is whole health? This is our definition that we're using of whole health, and I'm going to say more about it. Whole health is an approach to healthcare that empowers and equips people to take charge of their health and well-being and live life to their fullest. And what we like to say, our boss, Tracy Godet, who's been a great spokesperson for this, and we didn't invent this, but it's about changing the focus from what is the matter with you to what matters to you. And that's what your healthcare should revolve around. And if you just keep that in your mind, that's kind of a core organizing principle around what we're trying to do. So let me talk for a minute about this whole health system, which is the sort of operating system that we're trying to help install in the VA as the way to further this type of approach in the care of our veterans. So there are 3 components. I'm going to put this slide up again in a second, so I'm going to skip to the next one, which actually defines the components for you. The pathway is an experience that is not conventionally part of our approach to healthcare because it's non-clinical. So the idea of the pathway, which is ideally where veterans can start in this whole health experience, is that you engage in a conversation with a peer, not a clinical conversation, a partnership conversation, where you get to talk about what matters to you in your life. You get to do something called a personal health inventory. Start on your personal health plan. Think not necessarily about your problems, but also about your strengths, what makes you well, what makes you healthy. And then you get to start to think about what tools you might have to mobilize. So that's the pathway. That can happen in groups. It can happen individually. We're working on setting it up so it can happen online for veterans in rural areas who may not want to come into the facility. So then the second part of the system is what we're calling the well-being program. And this is where some of those tools that the veteran may want to use for advancing their health around what matters to them, this is where the facility can offer these tools. So these would be things like acupuncture, tai chi classes, whole health coaching, many different kinds of integrated modalities, and I'll talk about that a bit at the end. So this is a well-being program. Some of this is happening in the VA facility, some is happening out in the community. And the third part of the system is whole health clinical care, and this is in some ways the most challenging. This is where we help the physicians and the wonderful practitioners who were trained in a conventional model of care where they're very disease-oriented, and a visit with a patient is about checking off the plan for each diagnosis, which we all I mean, I'm a physician and I was trained that way, so I think many of us recognize the value of that. But we're turning that on its head and thinking about how to organize our clinical care around what matters to the veteran and around what their personal goals are for their health. So that's another aspect of our work, is really working on training those 330,000 employees in the VA so that everybody understands what that means to orient care around what matters to the veteran. So just to take a look at this again, you can see now how these circles all overlap, and each of them by itself isn't quite enough. So it's not quite enough to offer acupuncture by itself. It's not quite enough to offer clinical care by itself, even if it's whole health-ish. The pathway by itself doesn't address the diseases that people are struggling with. So the idea is we need all three parts of this system. And what you see in the middle is personal health planning, and this is where the veteran is working consistently with peers as well as with their clinical team to identify what matters to them and how to organize their care around that. So just to break that right down, what that might be is, what's important to you? This comes up in a conversation with a veteran and a peer. Well, I want to be able to get out and walk and spend time with my grandkids. It's not that what's important to me the most is getting my hemoglobin A1C down or my blood pressure down. It's to do those things because I will be more healthy and I will be able to do the things that I want in my life. So in a nutshell, that's kind of where the difference lies between the two. So just a quick little history. This has not been an overnight transformation in the VA. This is something that's been going on. This goes back 6 years. It's really been going on more time than that. But let's just say quickly, starting in 2012, the VA strategic plan defined the #1 strategic goal, and these are great words: provide veterans personalized, proactive, and patient-driven care. And this has been sort of the mantra in VA of this period of time. So they defined that as the goal. How exactly we would get there wasn't so well defined. So our office and many other offices were charged with sort of get out there and figure this out. We funded a number of centers of innovation. In 2015, the then secretary actually identified whole health as the VA's approach to delivering this kind of personalized care, sort of the delivery system. That gave a lot of momentum to the spread of this across the system. We were able to fund in a number of design sites around the country, and then came the CARA legislation, which I'm going to talk about more in a second. So this is just a map of some of the design sites where we funded modest programs to sort of have a VA facility be able to experiment. Well, what is it like to bring coaching into the facility? What is it like to try to have a peer-led conversation group with veterans about what matters to them? What is it like to try to retrain your clinical staff so that they think about these whole health principles? So we've been getting a lot of experience with this across the system in the last 5 years or so. So then this was a huge development, and this is, it's funny to be talking about this here, because normally when I give this talk, I say, that expression where it says, it would take an act of Congress to change something. So we had an act of Congress. And this is the Comprehensive Addiction and Recovery Act. This was passed and signed into law in July of 2016. And it's not all about complementary integrative health or health. Most of it is about pain care, addiction care, addressing the opioid epidemic. And it's aimed at VA, but also at DOD and at other parts of the federal government. So it's very wide in its scope. But there are two parts of it that really were directed at us in the VA, which have really provided a huge amount of momentum for us in this effort. So the first, Section 932. Whoever thought I would get excited about a section of a legislation, but I know it by heart. Section 932. So this charged the VA with developing a plan for expanding research, education, and delivery of clinical care in the area of complementary integrative health to veterans. And so this was a plan that we worked on a lot over the end of last year, and it was signed by the secretary in March of 2017. So we have a blueprint now for how VA is moving forward with increasing training for staff, increasing access to clinical care, and increasing its investment in research in this area. And that plan is really guiding our movement and our decision making. Then another part of the CARA Act, which is Section 933, mandated that VA stand up 15 pilot sites to look at the integration of complementary integrative health into the care of veterans, particularly with an emphasis on pain care, on mental health issues, and on well-being in general. So this was a mandate from Congress to set up 15 three-year demonstration programs around the country, evaluate them, and then report back to Congress about what is the outcome of bringing more integrative health to veterans. This is a very influential piece of legislation, just tucked away in the bill, just one little section, but this is having a huge impact on the VA. So what happened then? So based on this legislation, we have a mandate from Congress, we have to do this. So our VISN directors, who really control many things in the VA, including the flow of funding to their VISNs and a lot of decision-making about priorities, they decided not only were we going to do 15, but because there are 18 VISNs and nobody wanted to be last to the party, they said we're going to do 18. So we have now identified 18 whole health demonstration sites that began their work in the beginning of this fiscal year, so in October of 2017. And their mandate, their job, is to fully implement this whole health system, all three parts of the system, over the course of the coming 3 years, and basically help us measure what is the impact. What is the impact on veteran-reported well-being around things like pain, quality of life, engagement, function? What's the impact on disease-oriented outcomes? So are we improving people's blood pressure and weight, et cetera, their diabetes? What's the impact on cost and utilization in the VA? And what's the impact on staff engagement and staff satisfaction of staff working in this model? So these 18 sites are working together with us in a very large experiment to look at what's the impact of bringing integrative health and whole health more fully out to a large number of veterans. And the goal is, over the course of this 3 years, that we touch 30% of the veterans at each of these 18 sites with some aspect of the whole health model. And if you add it up, that's a lot of people. So a typical large veteran center might have 100,000 unique patients, and we're talking about actively touching 30,000 of those patients, and then multiply that out across the country. So really exciting opportunity. So just FYI, these are the 18 sites around the country. I will say Washington, D.C. is thankfully not one of them, if people have been following the papers. So, but there are many wonderful sites, Tampa, Atlanta, many of these sites really leading the way around how to bring this out into clinical care. So this is a great opportunity. There are a lot of challenges. There are a lot of competing priorities in VA. People are wanting to continue to be able to deliver quality primary care while they're delivering some of these new services. There's a new executive order that mandates that we expand mental health access across the VA to recently separated service people. So really a lot of challenges, but at the same time, there's a pretty strong conviction at the VA, really even up to Secretary Shulkin, that whole health is one of the things that VA can do that private sector can't do. It's one of the things that can really distinguish VA. Was that 5, Kelly? Okay, got it. So we really have a lot of momentum, and to be honest, it seems quite strong and solid. And what's great, too, is this is not a new thing in VA. VA has been moving in this direction of more patient-centered, patient-driven care for 6, 8, even more years. They've also been moving towards the medical home model that plans out a team function that says, one physician, one patient is not the model anymore. So there are a lot of things that have been happening in VA over the last decade that really build toward this model and we think are going to really help it be successful. So in the last couple of minutes I do want to shift away from talking about whole health and that larger approach and talk specifically about integrative health approaches and modalities. And this is the work of my office. We're called the Integrative Health Coordinating Center. So we're a subunit within the Office of Patient-Centered Care. And our job is specifically to try to move forward access to complementary and integrative health modalities for veterans across the country. So obviously not just at these 18 flagship sites, but really across the country as a whole. And our job is also to help support education of staff and help support the movement of the VA's research agenda forward in this area. So once again, whoever knew I'd get excited about memos and directives? I was a clinician in the academic medicine world for 25 years, but I am. So in May of 2017, VA passed what's called a policy directive. And so this policy directive, again, is having a huge impact on VA care. This was in the works for a number of years because, as you'll see, it really pushes the envelope quite actively as far as what VA is offering. And basically what this policy directive says is that complementary integrative health approaches with evidence of promising or potential benefit must be provided to veterans as part of the standard medical benefits package. So this is, I'm just going to say it again, we sometimes still are stunned ourselves, 2 minutes. VA, as a health system, has committed to cover the promising, evidence-based, integrative health approaches, where appropriate, for the entire patient population. So this is a step that VA has taken that really, in my thinking, no other large health system has taken on this scale. So what are we talking about? That we have a system in place that's laid out by that policy directive for vetting the complementary integrative health approaches, and basically, do they pass the bar for published evidence of effectiveness? We're an evidence-based system, so in order to become widely deployed as part of standard medical care in the VA, a therapy has to really have proven itself. So these are the therapies to date that have passed that bar and that are now being offered as part of standard medical benefits to veterans, where appropriate, as part of their conversation with the treatment team. And so you can see the list. I won't read it. I do want to note that chiropractic has been offered to veterans as a standard of care for over 10 years, and that was by a specific mandate from Congress in the mid-2000s. So we don't count chiropractic under our umbrella, but that's another integrative approach that's being widely rolled out to veterans. 1 minute. Okay, so this is big news, and it's not unchallenging. VA is working hard to figure out how to actually offer these things. Particularly, you have rural populations, you have parts of the country where people are just not perhaps familiar with Tai Chi. We had one facility director say, my veterans want to go hunting and fishing for their relaxation therapy as opposed to learn Tai Chi. Do I really need to offer them Tai Chi? And we said, well, you know, maybe you want to offer both, or maybe you want to do Tai Chi while they're out hunting and fishing. So, and you know, Tai Chi is evidence-based, hunting and fishing not yet. So, this is really exciting from our point of view, and we think this is a really amazing opportunity because we're also strongly connected with the Office of Research and Development and the health services research community within VA. So we have an opportunity to really do some meaningful research looking at the impact of these therapies being more widely available to the veteran population. Focusing on pain, focusing on mental health, but also focusing on well-being and quality of life. So I just wanted to end with a revisit of this slide to just make the point again that this is not about substituting acupuncture for opioids in the treatment of pain. It's really about, as Eric was saying, helping reorient the care around what's important to the person, and really around the person as opposed to the disease. The integrative health approaches are in service of that. They're super important tools, and thankfully we now have those in our toolbox in the VA. And we're really hoping that this model will become a model that, you know, the whole country wants to look at and that we can really learn from in terms of its potential impact. I think I'm done.